Hi guys, welcome back. We're going to quickly try to go over 15 questions because I have another 40 questions to do and two CMS forms and just 3.5 hours left. Stay relaxed and try to push, push, push. So yeah, this is pretty much hepatocellular carcinoma is probably the only reason why you get bloody ascites. See, ascites can be bloody, as in this patient, or non-bloody, depends on the etiology. Bloody ascites is caused by RBC leaking into peritoneal fluid. Most cases are due to localized trauma during paracentesis. That is self-limited. However, bloody ascites that persists on multiple paracentesis pathologies suggests an underlying malignancy. Hepatocellular carcinoma is the most common malignancy. It has risk factors include cirrhosis, chronic hepatitis B, hepatitis C infection, environmental toxins such as aflatoxin. Less frequently, bloody ascites can be due to metastasis from different distant sites, such as ovaries and prostate. Patients should undergo abdominal imaging, measurement of serum alpha protein, and abdominal imaging, alpha fetoprotein, and cytological analysis. Rarely, patients can have hemorrhage from hemodynamic stability that warrants catheter angiography with embolization. Nephrotic syndrome typically causes a non-bloody ascites, although portal venous thrombosis can cause ascites, but it's non-bloody. Yeah, that's it. Uh, and it will have abdominal pain. That is an excellent point. Nephrotic syndrome. Spontaneous bacterial peritonitis typically causes non-bloody ascites. Yeah, furthermore, patient will have fever and all that. Tuberculosis can spread to peritoneum. However, fluid generally appears straw-colored. So that's great. So a little bit about ascites. Portal venous thrombosis causes portal vein thrombosis will cause non-bloody ascites with local pain, with tenderness, which is absent in this patient. Wait. Uh, yeah. The next one is, yes, pulmonary embolism. So I didn't recognize this at all, and I was still thinking it is cardiac arrest. Let's see. Causes of pleuritic chest pain: costochondritis, pericarditis, malignancy, and infection. Pulmonary embolism is a relatively common life-threatening cause of pleuritic chest pain and should be strongly considered with risk factors. Okay. Did this patient have recent hospitalization with prolonged immobilization? My lower extremity edema, but this was hard for me. It really was. Um, let's just mark it. Let's go from back. Yes. Skin lesion, Lyme disease. Anything about Lyme disease that I want to write here? So, Lyme disease is caused by a spirochete. Is endemic to northeast. So this is west coast, east coast. Erythema migrans is commonly arterioventricular block. See, what are questions about Lyme that I would have to answer? So Lyme can also cause facial palsy. Okay. Yeah, there's three stages immediately. So early, then disseminated, and late. So early we have erythema migrans, myalgia, fatigue, all that stuff. In disseminated, we have cranial nerve 7 palsy, meningitis, and migratory arthralgia with AV block. Those are some things. Fragile X syndrome, nothing to do with lines. Um, yes, then removal of ticks should be ASAP. If it's less than 36 hours, do not need antibiotics, which is generally single dose doxycycline. Okay, in pregnant patients with Lyme, we give amoxicillin. Okay, so this is a um, really nice sketchy image, which I feel I need to see again. Yeah, stage one target, stage two, AV block, stage three. Let's see. Heart block, Bell's palsy, encephalopathy, and migratory polyarthritis. Yeah, so these three early symptoms will be flu and bullseye rash. Then disseminated would have AV block and Bell's palsy. And then late we would have encephalopathy and migratory polyarthritis. Okay, so that's it. Yay. Next we go to, yes, liver laceration. Patient with uncontrolled blood pressure post-trauma. If a patient comes with blunt abdominal injury, with persistent hypotension, immediately go to liver laceration. And no, this will cause intraperitoneal fluid. Should know some other things here. Um, Abdominal aortic injury would just die. Pancreatic injury will cause retroperitoneal bleeding. BAT would not cause hemodynamic instability. Sorry, urinary bladder would not cause instability. And splenic, I used to think it would cause hypertension, but it is self-sustained. Let's see why. What does splenic laceration cause then? This patient simply didn't have it. Yeah, atypical glandular cells greater than 35. Let's do endometrial biopsy. Let's wait. Uh, Laryngomalacia. Again, what is laryngomalacia? Shows intermittent collapse of arytenoid cartilage with inspiration. Although the etiology of this condition is not precisely known, patients typically have an omega-shaped epiglottitis, short array-epiglottic folds, and characteristic inspiratory collapse of the supraglottic tissues, leading to partial obstruction of the airway and thus inspiratory stridor. Laryngomalacia presents with inspiratory stridor due to dynamic collapse of the supraglottic tissue on inspiration. Stridor increases in periods of increased airflow, such as crying. Why not biphasic? Compared with trachea and supraglottic larynx, the subglottic larynx is less flexible because it's supported by a complete ring of cartilages. Okay. There's minimum change in subglottic airway caliber and inspiration compared to the expiration. Therefore, conditions that result in subglottic narrowing often lead to biphasic stridor. Okay. Some concepts to understand what laryngomalacia, tracheomalacia, biphasic stridor, inspiratory stridor. Okay, so revise this a little bit. So starting from the top, we have larynx, glottis, subglottic region, trachea. Laryngomalacia is the most common cause of stridor in kids, especially during crying and in supine position when the tissue falls into the airway. So they improve on prone position. Laryngomalacia is inspiratory stridor. So the inspiratory group is going to be inspiratory stridor again. At glottis, subglottic level is going to be biphasic because it's the nervous part, it's going to affect both. But tracheomalacia is going to expiratory stridor. So that's all you need to know. Palpable breast mass. Again, I think I have to rethink this whole thing because I keep getting it wrong. Mm, okay. So breast masses in young adolescent is okay. Give reassurance and all that. But if it's less than 30, do an ultrasound plus mammography. It's greater than 40. Mammography plus ultrasound. Okay. So next one, Hirshsprung. Have 10 more questions to review. That's stressful, but okay. Let's eat a little, then let's review it. And then it's a 20 questions review, PED CMS review, 20 questions review, OBG CMS review. Okay. Pulmonary embolism. Not very sure. So let's see. Pulmonary embolism is the most common life-threatening cause of pleuritic chest pain and should be considered in patients with risk factors. Suggestive clinical features dyspnea, tachycardia, tachypnea, unilateral lower extremity edema. Patients with high pretest probably should be evaluated with CT angio. Pleuritic chest pain. Okay. Patient has several features: dyspnea, tachycardia, and unilateral lower extremity edema. Pleural effusion, low-grade fever, and troponin elevation can also be seen. These are features of pulmonary embolism, likely explanation of the presentation. CT, angio. T-dimer is used for excluding patients with low pretus probably. The patient is at risk of recurrent acute coronary syndrome. Emergency coronary angiography is indicated for ST segment elevation. However, this should present with ST segment elevation on ECG rather than pleuritic chest pain. Serial ECGs and troponin levels are indicated for suspected non-ST segment elevation or MI. But these acute coronary syndrome manifestations should present with ischemia rather than pleuritic chest pain. So one very important central idea is that uh, chest pain. What is pleuritic chest pain would be something I would ask myself. Patient with cancer or recent surgery, despite prophylactic anticoagulants, tachycardia and tachypnea. Hmm. Low-grade fever. Okay. Wells criteria. Less than 4. Yeah, this needs to be revised again. So a few
This one, like telltales of pulmonary embolism. One, it will be pleuritic chest pain, unlike ischemic pain. The second thing will be in patients with cancer and recent surgery, and they present with tachycardia and tachypnea. If it's low pretest, we do D-dimer. If it's high pretest, we do CT angio. High pretest, we do CT angio. Okay, right. Let's go to the next one. It's definitely something I have to come back to, but so far I think it's okay. Then here, for alloimmunization, that is erythroblastosis fetalis, anti-D immunoglobulin should be administered when delivering an RHD positive. Standard dose is usually adequate at 28 weeks. After delivery, the Klehor-Betke test is used to determine whether higher dose is needed for increased risk of fetal blood entering the maternal circulation. The woman indicates that she is Irish and the anti sensitized. 28 weeks gestation and within 72 hours of delivery. 300 microgram at 28 weeks. Yes. Okay. So in erythroblastosis fetalis, what happens is if it's 1:32, it means it's sensitized. If we're at 28 weeks, around 300 microgram of anti-D, and then post-delivery, it should be using the Clee or Bedke test to determine amount of fetal hemoglobin. Great. Yeah. Okay, so we have heavy menstrual bleeding with anemia, normal coagulation studies, normal coagulation studies, with probably a prolonged APTT, activated platelet thrombin time, because this is because of factor VIII. It's going to be von Willebrand's disease. Yeah, management of chronic stable angina. We're going to use beta blockers, ca- calcium channel blockers, dihydropyridine calcium channel blockers, nitrates, ranolazine. Um, Yeah, this needs to be a page of its own. So one more is what is the mechanism of action of each of those drugs used in chronic stable angina? First line is beta blockers. So beta blockers, you will say it will decrease heart rate, decrease contractility. This is a repeated answer. Just take it. The second one is calcium channel blockers, which will decrease uh, contraction. So afterload is decreased, and it causes systemic arterial vasodilation. Nitrates will decrease preload. So that's it. Okay. So nitrates decrease preload. Calcium channel blockers will decrease afterload and will cause systemic arterial vasodilation. Non-hydropyridine will cause decreased myocardial, but again, this beta blockers causes a decrease in cardiac uh, myocardial contractility. So this is very simple. So in stable angina, first line is beta blocker, and this causes myocardial contractility to decrease. It causes heart rate to decrease. Next, calcium channel blockers causes afterload to decrease. And nitrates causes preload to decrease. Okay, next. So this manifestation of hypoglycemia, they will present with sweating, palpitations, tremors, and they regain once they consume high calorie food because that increases the blood glucose. This is not glucose that's taken up by the cells, but the glucose that exists in the blood. So it's glucagon related. Pediatric stroke, yes. Sickle cell anemia is the most common cause of pediatric stroke. Can cause altered. Okay, mitochondria, male skin. Stroke in young. It can be sickle cell, which will do hemoglobin electrophoresis. It can be prothrombotic diseases, meningitis, vasculitis, trauma. Okay. But the most common we would go with sickle cell. Most common cause of pediatric for hemoglobin electrophoresis. Okay, yeah. What's the next thing? Effects of maneuvers on hypertrophic cardiomyopathy. Yeah. Hypertrophic cardiomyopathy increases in intensity with maneuvers that decrease left ventricular blood volume and worsen left ventricular outflow obstruction. Some things to understand here. I feel like I just want to skip it, but 4 more questions. And then we have to do let's take a quick break. Okay. So maneuvers for hypertrophic cardiomyopathy. When do you think of hypertrophic cardiomyopathy? If a patient's parent experiences cardiac arrest and the patient is young and experiences cardiac arrest, HCM is an autosomal dominant condition that should cross your mind. The mutation results in asymmetrical hypertrophy of the intraventricular septum that can lead to dynamic left ventricular outflow tract obstruction. So, maneuvers that decrease left ventricular blood volume, reduce venous return that occurs with Valsalva strain phase or standing from a supine, decrease left ventricular size. This worsens the left ventricular outflow tract. So, more blood there would be better. Squatting increases blood volume, increases venous return, so it will reduce the intensity of the murmur. Venous return to the heart is increased by the assumption of supine position from standing. A sustained hand grip increases afterload to increase left ventricular blood volume and reduce the intensity of HCM murmur. So the answer is Valsalva strain phase. So I'm not sure what that is. Let's just look at a picture quickly. Decreases the blood return. So that's the answer. Okay. So the question is patient who is young, male, and his dad had cardiac arrest. We think of HOCM, and HOCM murmur decreases when blood volume return increases, and it increases in from supine to standing, and then in Valsalva strain phase. Because in these of them, blood return decreases. HCM is interventricular septum is thick. The next one is yes. The patient's repeated nocturnal episodes of violent, automatic, complex motor behavior is consistent with rapid eye movement sleep behavior. dream enactment because the muscle atonia that usually accompanies REM is absent. Episodes typically occur at 90 minutes after sleep onset, coinciding with the onset of REM sleep. Okay. Most frequently in the second half of the night. Mean age is greater than 50, and it represents future development of alpha synuclein neurodegenerative disorder. So it increases the chance of Parkinson's disease or another, such as dementia with Lewy bodies or multiple system atrophy. The rate of conversion of REM sleep behavioral disorder to Parkinson's disease is approximately 50 years for every 10 years, 50% for every 10 years. Although Although rapid eye movement behavioral disorder may occur in these non-synuclein neurodegenerative disorders, much more commonly associated with Parkinson's disease. Furthermore, RB is not considered a prodromal marker for these non-synuclein disorders. Yeah. Okay. So rapid eye movement disorder is after 90 minutes, we have dream enactment because of loss of muscle atonia. And this increases alpha synuclein. So increases Parkinson's disease, increases Lewy body dementia. Great. What's the next one? Yeah, major depressive. I didn't get this, but okay. Hirshsprung. I have Hirshsprung disease. So failed neural crest cell migration, absent parasympathetic ganglion, delayed passage of meconium, bilious emesis, distended abdomen, tight anal sphincter, forceful stool expulsion, the squirt sign, narrow rectosigmoid area with dilated proximal colon, impaired relaxation of internal and anal sphincter. Okay, the child's chronic constipation, thin caliber stools, and abnormal rectal exam are concerned for Hirschsprung disease, a condition in which failed neural crest cell migration results in ganglionic colonic segment. Patients with a long segment of affected colon classically present in the newborn period with delayed passage of meconium. However, in patients with short aganglionic colonic segment, diagnosis is often delayed until later in infancy, including chronic, yeah, short, okay. Classic rectal examination in patients with Hirschsprung disease reveals an expulsion of stool or gas due to temporary relief of the obstruction. Additional findings, normal distension, thin caliber stools. Okay. Blood with bowel movements may be seen with anal fissures or hemorrhoids caused by straining. The first step is to perform contrast enema. Okay, to see a transition zone. Although limiting cause in this patient's constipation since early infancy and a positive squirts and are concerning for underlying pathology such as Hirschsprung warrants for further disease. Okay, so my question over there was in this question stem, why did the in this question stem we have those explosive stools and worsening after shifting milk. Why not lactose intolerance? Rectal examination results in expulsive. Okay. I think this issue won't be there in the NBME or CMS form because it's not this. Tools on rectal exam. And we simply, what do we do here? Contrast enema. This also happens in lactose, but this is acidic diarrhea, acidic diarrhea throughout the day. And there's an important distractor from mother's milk to cow's milk. Some constipation increases. Great. So, yay, done with this block. Let's do the next one.